Well, first I want to start with a syllogism that is written in no textbook but widely believed in practice, and that is that surgery is painful, opioids are painkillers, and all surgery requires the use of some opioids. So the question I'd like you to answer in your own mind is, if opioids are so effective against pain, why do patients require postoperative rescue? Now, I have a very unusual practice, a boutique practice. I practiced 41 years clinical work, and the first 15 years were with opioid-based anesthesia. And the last 26 years, I practiced in an office environment that did often not have an anesthesia machine, so the option to convert IV sedation to general anesthesia didn't exist. The option to paralyze and ventilate a patient didn't exist because there's no machine and no ventilator. So it was a very different sort of practice. Over the years, I've evolved the Friedberg's Triad, but I understand that not every anesthesia setting has the availability to do brain measurement, especially with the most common one, the BIS monitor. So I'll remind you that in the first 5 years of my office-based practice, I didn't have a brain monitor, and it was 10 years before I even got a quantitative infusion pump. So basically, it's hard to imagine a more primitive setting. Now, in the office, we typically have a secretary to admit the patient, a surgical scrub to help the surgeon, the patient, and myself giving both anesthesia and providing circulating. That's it. It's a very primitive environment, and we're doing cases as big as abdominoplasties, xiphoid to pubis reflection of the abdominal wall. So basically, Friedberg's Triad is the three principles that guide your pathway to opioid-free anesthesia with better pain and postoperative nausea and vomiting outcomes. Measure the brain, preempt the pain, emetic drugs, abstain. If you do a Google search, and like I said, you have to know that this term exists, but if you do a Google search of Friedberg's Triad, you'll find 8 pages and 55 mentions of Friedberg's Triad. Next slide, please. So why opioid-free anesthesia? Well, there's this nasty thing called opioid-related adverse drug effects, or RADAs, and the problem is that all these things happen outside of your operating room, so it becomes someone else's problem. And of course, the number one concern we'll talk about in just a second. Let's have the next slide, please. Any one of these RADAs in a hospital setting gives you an increased length of stay, a higher cost of care, increased 30-day readmission rate, and a much higher mortality risk. Next slide, please. So number one is measure the brain. Why do we want to do this? Believe it or not, in the fall of 2005, the Anesthesia Patient Safety Foundation newsletter published my letter to the editor that the brain is the target organ for anesthesia. So I don't know if there's a better argument for the fact that we're medicating the brain. I often say, look, you would never give a blood pressure medication and fail to measure the blood pressure response. And yet, without a brain monitor, we're routinely providing medication to patients and not measuring the response. So measuring is clearly better than guessing. Lord Kelvin said famously, if you cannot measure it, you cannot improve it. Typically, we use body weight. That's the most common thing, but in your world, TCI exists. We don't have that in the United States. Changes in heart rate and blood pressure, pharmacokinetics, pharmacodynamics, body mass index. Wonderful things, but they have nothing to do with the sensitivity of the brain. Next slide, please. So we get to the BIS monitor, and this is information that took me from 1997 to 1998 to develop. The slide, the upper left-hand corner, which shows a single trend of the BIS, the trouble is we look at EKG trends and pulse oximeter trends, and no matter how many times they told me that this information was delayed from real time by 15 to 30 seconds, I'm still looking at the trend, and I can't get my mind to accept the idea that I'm really looking in the rearview mirror. This is where the patient's status was 15 to 30 seconds ago. I want to know what's about to happen, not what already happened. And so after a year of complaining to the salesman that I can't seem to make this thing work. We're going along fine, and all of a sudden, there's a dramatic change. He finally says, "Well, why don't you trend to EMG as a secondary trend?" And if you look carefully in the lower left-hand corner, you see two trends, and you see these little red spikes there. Those are EMG spikes, and they signal incipient arousal. That's the patient's way of saying, "Doc, I'm about to wake up. Could you give me a little more propofol?" And once you return that spike to baseline, you see that there's really very little change in the BIS value as it trends across from left to right. So Karen Domino and group did a closed claims study of patients who were aware under anesthesia and recall, and found out that at least 50% of those patients had no changes in heart rate or blood pressure to alert the anesthesiologist. So there you have the big problem, and this is my problem with the current generation of nociceptive monitors, that typically they rely on heart rate changes, and we already know that they're not reliable. So I'm happy if it turns out that it works, it's great, but I'm very skeptical, and I look forward to seeing more information. Next slide, please. Now here's the kicker. Miller's Anesthesia 2025 edition states without qualification that IV sedation occurs from 25 to 75 micrograms per kilogram per minute. The reality is when you measure and titrate to BIS 60 to 75 with baseline EMG, you see 2 to 200 mics per kilo per minute is required to achieve the same numerical level of sedation. Now, what did I do before the brain monitor? I titrated to loss of lid reflex and loss of verbal response before giving my 50 milligrams of ketamine. I was very much concerned in the early days of establishing the principle, does propofol block ketamine hallucinations? We'll talk about that a little later, but the whole idea that you have a 100-fold difference in propofol rates to get to the same level, numerical level of sedation is completely foreign to Miller's Anesthesia, the #1 textbook in the field. So that was part of the basis of my recent post on LinkedIn. Next slide, please. How do I do it? Well, I'm going to show you how I do it. The YouTube clip has been up for 10 years and it's had over 83,000 people. The value of incremental induction is that it rapidly tells you who's the 2 microgram per kilogram up to 200 microgram per kilogram per minute patient. So you're avoiding over medication and under medication. It preserves spontaneous ventilation and patent airway. Again, if you don't have an anesthesia machine with a ventilator, it's going to be a long day in the office if you have to manually ventilate somebody for a 4-hour case, and totally impractical if you have to do that for a facelift. The point of the incremental induction is that it prevents the difficult airway and provides less stress for both the patient and the anesthesiologist. When you listen to this little 2-minute clip, you realize there's no pulse oximeter change with sedation onset. At any rate, we start off at 25 mics per kilo per minute with a 50 microgram per kilogram bolus. You say, how in the hell can you put an adult patient to sleep with those ridiculously low doses? Well, again, these are elective cases, so we're not talking about a ruptured aortic aneurysm or a prolapsed umbilical cord. We're talking about the bread and butter of most cases. I guess we're not going to hear the full size. I think you can see the 97 in the upper left-hand corner of the BIS, and as she starts to go off to sleep, you'll see it drift down into the 70s.
Will I be twitching?
No twitching.
But we don't have to manipulate the airway. We don't have to lift the chin. We don't have to stick an artificial airway in. We say we've already gone down from 97 to 88 with these ridiculously small doses. It's a little like solving the area under the curve for calculus. You know, you keep doing smaller and smaller increments until you get to a rectangle, and then you can solve the area under the curve with a rectangle formula. You see how quickly we've gone down? and yet the pulse oximeter doesn't change. The airway doesn't require manipulation. Pretty simple, pretty sweet, and it's very gentle on the patients.
And when I get home, can I eat?
Yes.
How do immediate?
I guess you'll have to take my word for it that the pulse oximeter doesn't change. It doesn't. And you can probably believe that because nobody's hanging onto the patient's chin,
If I wake up,
nobody's shoving an airway in her mouth.
anesthesia is.
Pretty nice.
I eat, right?
Yep.
And it doesn't really take a whole lot of time.
How many?
It's 2 minutes and about 26 seconds, which compares favorably to the usual bolus induction and paralytic and intubation and confirmed the placement of the endotracheal tube. One of the first patients I had that only took 2 micrograms per kilogram per minute was a Eastern European anesthesiologist who, when I told her we were going to use propofol, she said, "Propofol? The last time they gave me propofol, I slept for 2 days." So you can imagine if somebody only needed 2 mics per kilo per minute and you're giving 25 to 75 mics per kilo per minute, why she might have slept for such a long time. Okay, here's a little better picture of what the EMG looks like. And so to make it simple, I say when the red goes up, the white goes in. And if you prevent arousal, you don't have nociception or pain. You think about the hand touching the hot stove, that the hand withdraws before the mouth says ouch. So if you prevent arousal, you prevent nociception. And again, I'm not using anything besides propofol and 50 milligrams of ketamine. And we'll talk about the type of analgesia I've used, but that's pretty much what it looks like. And you don't see any dramatic change in the BIS value because that's where the patient was 15 to 30 seconds ago, and the EMG trend is where the patient is immediately. Most of us like to drive the car looking through the windshield rather than just in the rearview mirror. Okay, so this information that the BIS, the EMG is the signal of incipient arousal came from the ASA publication in 2006. Again, maybe not widely appreciated, but as more and more patients are having regional anesthesia, more and more patients are breathing spontaneously, meaning you can, in fact, dial up this EMG trend. Okay, next slide, please. The second part of Friedberg's triad, preempt the pain. Well, as Ben Franklin said, an ounce of prevention is worth a pound of cure. So dial back to 1993, I've given my first 50-case propofol ketamine presentation, and I am so excited to share this experience that I've had, that I've found a way that patients don't have pain or nausea and vomiting. And instead of curiosity, I'm greeted with excoriating criticism and the comment, "You must be crazy. No one gives ketamine to adults." And what I wish I would have said is that your patients still have pain and PONV and mine do not. Who's the crazy one? So this has been a long, strange trip to go from excoriating criticism to creeping credibility. Thank you very much. Next slide, please. So this was basically opioid free from the start. In 1990, a plastic surgeon that I worked with at the hospital setting in the 1980s, Ed Damascus, experienced a fentanyl-related death in an elective cosmetic surgery patient. Needless to say, it was a bad show. A little later, I attend a meeting, a presentation by a plastic surgeon from Las Vegas named Chuck Vinnick in 1991, who talked about his diazepam ketamine technique. And of course, he managed to do that by himself. And I asked him when I went to visit him, I said, "Well, what do you think about using propofol?" And he says, the only reason you want to use that drug is expensive. Okay, so in 1992, when I started to work with Ed in his office, Damascus, there was no information available. Nobody could tell me, I couldn't read anywhere, I couldn't find anywhere, does propofol block ketamine hallucinations? Needless to say, the first 25 cases, I know the first patient who wakes up hallucinating, I realized that propofol must have some unique quality or diazepam must have some unique quality that propofol didn't. When I proposed this as a publication to the 2 major U.S. anesthesia journals, they rejected it even though it was novel information. And the reason most likely they rejected it is it didn't originate from a university setting, and therefore, what could this person possibly know? So Plastic and Reconstructive Surgery, the major plastic surgery journal, published the letter in 1993. Yes, indeedy, hypnotic dose, hypnotic propofol blocks ketamine-induced hallucinations. And this set the stage to promote office-based opioid-free anesthesia. Next slide, please. So why do I insist on giving 50 milligrams of ketamine and not what everybody knows, 0.5 milligram per kilogram? Because ketamine is a unique agent. There's no other agent that we have that's turned out to be useful for refractory depression, PTSD, chronic pain. Ketamine is a very unique compound. And if you want consistent outcomes, well, for 26 years and over 6,000 patients, giving 50 milligrams of ketamine instead of a 0.5 milligram per kilogram has resulted in very consistent immobility for 10 to 20 minutes in patients between 30 and 145 kilograms. So now, if you see this, it's very hard to explain that really the effective dose is a body weight basis. I reject the idea. I'll also throw it in as a bonus that this experience was in patients as young as 7 all the way as old as 94. So the number of NMDA receptors in the midbrain doesn't appear to be body weight related. And if you want consistent outcomes, 50 milligrams is what you want to use and not a 0.5 milligram per kilogram. Okay, next slide, please. I like to express the 50 milligrams of ketamine as the olive for the propofol martini. There are many people around the world who mix the two drugs. And the problem with the mixture, multiple problems, are there's no uniform definition of the ratio of ketamine to propofol. Some put 20 in 200, some put 50 in 200, some put 200 in 200. And the problem is you can't, once you've mixed them, you can't really discern which drug is giving you which effect. So propofol first, then ketamine. How did this all get started? Well, the guy who wrote about diazepam ketamine used a hyphen between the two drugs. And when I started writing in 1993, I'm ashamed to tell you I didn't really know anything about writing. I just copied what he did, and people assumed when they saw propofol hyphen ketamine, they thought I was talking about ketofol. But it really is propofol, then ketamine. Okay, next slide, please. This is the biggest patient I rendered immobile with 50 milligrams of ketamine. We pumped about 1 liter, maybe 2 liters in each upper arm, and we sucked out 1.5 liters of fat. Hard to believe. But again, when you see this, you say, well, how can the effective NMDA receptor saturating dose be body weight related? It simply can't. Next slide, please. So what is the outcome of what I was doing? Again, 26 years of doing the same thing. I don't have a contract, okay? My only job security is my outcomes, okay? So the simple formula is incremental propofol induction and maintenance, 50 milligrams of ketamine IV, tumescent, wait 2 to 3 minutes to let the full saturation occur, and then inject very noxious tumescent subcutaneous analgesia. There have been no pain or PONV hospital admissions, even though all patients had commercial insurance. You simply can't do this in an office setting and create problems. You have to get good results, and keeping it as simple as possible is one thing. I'll talk about my clonidine experience a little later. Next slide, please. The last part of Friedberg's Triad is probably the most contentious, and that is the opioid-free part. Okay, next slide, please. There's a fundamental disconnect between what we believe in anesthesia is the most important thing and what patients have said on a scientifically validated study. This is Alex Beccario at Stanford. He did these 2 studies that were scientifically validated surveys in 1999, and patients were asked to rank the outcome they most wanted to avoid, 1, 2, 3. Number 1 was the most important one to avoid. And patients chose emesis as number 1, gagging on the endotracheal tube number 2, and nausea number 3. Pain came in at a distant number 4. As an anesthesiologist, you say, does this mean patients want to have pain? No, they don't want to have pain. They expect some level of discomfort. They've signed a surgical consent that says, okay, you can stick me with a knife or poke me with a trocar, and I expect some discomfort. But I don't expect to throw up like crazy afterwards over and over and over again. So this is the fundamental disconnect. And the problem is that the emesis doesn't happen in the operating room, so it gets shuffled off to the recovery room. Well, in my practice, in the office-based setting, there is no recovery room. The operating room is admitting, surgery, and recovery, and there's no hiding from your outcomes. Patients either wake up not sick to their stomach, or they are, and it's not going to be good for being asked to come back another time if your patients are sick to their stomach. Next slide, please. So the question comes up, well, geez, Dr. Friedberg, we give antiemetics. I mean, what's the problem with giving opioids? So the fourth consensus guideline, which came out in 2020, included 22 academic authors, 22. And according to their recommendation, you should be giving one antiemetic for every APFL risk factor. Okay, sounds perfectly reasonable, very mainstream. Okay, next slide, please. This is the paper that I published on my first 5-year experience. Again, this 5-year experience did not have a quantitative infusion pump and didn't have a BIS monitor. This was all titrating, dripping from a bag, and titrating against airway maintenance and pulse oximetry. Okay, my cohort is all 4 APFL risk factors. 80% were non-smoking females with PONV, motion sickness history, having emetogenic surgery, and cosmetic surgery is one of those surgeries that APFL recognized. When he published his article on the 4 risk factors, I reached out to him. I said, hey, you're talking about my patients. And so we had a nice relationship, and he was kind enough to cite me in Miller's Anesthesia. Next slide, please. So there you have it. I have 4 risk factors. I've given no antiemetics. I have a 0.6% nausea and vomiting rate. That's 7 of 1,264 patients over a 5-year period. And all 7 who were asked said they would have the same anesthesia again. It's a pretty good endorsement, I'd say, and nobody's come even close. I think in the PONV chapter that APFL wrote in Miller, he compared my 0.6% to Paul White's 7%. So I figured anytime you're compared to Paul White and do 10 times better, you must have done something pretty reasonable. Next slide, please. So here's Christian APFL, and there's Miller's Anesthesia. So the question I have to ask is, this was all published. I mean, this is not an obscure textbook. Miller's Anesthesia is the #1 textbook in the field. Here's 22 academicians who certainly know this book. And I say, how is it possible they didn't read either one of APFL's chapter in Miller's Anesthesia before writing this consensus paper? And the only answer I could come up with was the Rodney Dangerfield answer. I get no respect because I'm not an academic person. And I think, to me, as a non-academician, to be cited in the #1 textbook in anesthesia is pretty impressive. I was thrilled. And then when the 2020 edition came out, there was no dedicated PONV chapter, as there is also none in the 2025 chapter. And that was the subject of my LinkedIn post. I said, what's the deal here? So the answer may be that in cosmetic surgery, the consequences of nausea and vomiting in a facelift patient, which may cause a hematoma in the flap and be very bad for outcomes, or in a tummy tuck, an abdominal patient, abdominoplasty patient, may rupture those sutures they put in the rectus sheath imbrication. That's really, really bad. Whereas with have to surgery, medically indicated surgery, well, it's a problem, nobody dies, it doesn't happen in the operating room. We can only get so excited about this, so it's really not worth a dedicated chapter in Miller's Anesthesia. You say, well, the problem is that the patients Macario surveyed were not cosmetic surgery patients. They were just run-of-the-mill medically indicated surgeries. So what did APFL say on the subject of antiemetics? He said, as long as As long as emetogenic agents are part of the anesthetic regimen, the use of antiemetics is of limited utility. Now, limited utility is an academic speak term, meaning doesn't work very well for those of us who are in non-academic anesthesia. This is one of my earliest converts, Chris Apfel in Hull, England. He says very simply, if you want patients to stop throwing up, stop giving them drugs and make them sick to their stomach. So until people who are intimately involved with medically indicated surgeries, which is mainstream anesthesia, make a value proposition to avoid nausea and vomiting, simply following the consensus guidelines isn't going to do the trick. You have to make the change. And again, we get back to Einstein's definition of insanity, right? Just doing the same thing over and over again and expecting a different outcome. As long as you're giving opioids, you're going to have nausea and vomiting as a problem. Next slide, please. So the nuts and bolts of how I do it, it took me a long time to figure out what the symbol on the left was because it's small in the triad. It's actually an opium poppy. And if you know that's an opium poppy, it becomes very obvious. Now, I always start the case with 2/10 milligram glycopyrrolate to mitigate the salivation that the ketamine causes because, as we'll see in the slide later, saliva in the airway is a notorious cause of laryngospasm. So after the glycopyrrolate, we give the incremental propofol induction and we maintain it to either loss of lid reflex and loss of verbal response before the ketamine, or BIS below 75 with baseline EMG. And then 2 to 3 minutes before the incision or the injection of local anesthesia, 50 milligrams of IV ketamine. And 2 to 3 minutes is needed because the saturation effect takes more than one circulation time. And then we talk about pre-stimulation, tumescent, subcutaneous analgesia. Now let me go back to something here about the ketamine. If you're doing a single injection local anesthetic for an epidural or a spinal or a scalene, interscalene block, you don't need the ketamine to mitigate a single needle injection. But you do need it before the incision because there's non-nociceptive input like pressure and movement that can send a signal to the brain that says, hey, you may be asleep, but you signed a consent for surgery and something's going on. And with that signal, the internal pain fibers go up and you have lost your preemptive analgesia effect. And then before closure, you can tell that I'm an old timer because we didn't have ropivacaine when I was working, and that's okay. We used pre-closure bupivacaine, but we didn't inject it, we just splashed it in the wound. 50 cc's of 1/4% or 100 cc's of 1/8%. Just splashed in the wound, it quickly binds the tissue, and you get some marvelous postoperative analgesia. Next slide, please. What is subcutaneous tumescent analgesia? Just what it says. You inject it in the subcutaneous area. Jeff Klein is a local dermatologist here in Orange County, California, published this stuff in 1990. He was originally inviting the local anesthesiologist to his office to give general anesthesia for liposuction. And when the local plastic surgeons found out, they said, you can go down there and work with this guy, but if you ever give him a case, you'll never do another case for us. So here he was all set to do general anesthesia. He said, how do I figure out a way to give analgesia without needing an anesthesia machine? And so the tumescent formula is very, very simple. He's made it a little fancier, but doesn't need to be. 500 milligrams of lidocaine and 1 milligram of epinephrine in 1,000 cc's of either saline or lactated ringers gives you a concentration of 0.05% lidocaine and 1 to 2 million epinephrine. And you can see what he published is 35 milligrams of per kilogram for liposuction and 28 without liposuction are reasonable doses. It's pretty amazing when you see I didn't include the abdominoplasty clip because I figured it was just going to be too much. I tried to keep this very basic. Next slide, please. So is this only for cosmetic surgery cases? Well, one of my friends that trained around me, Ehab Akari, was doing bariatric surgery in the hospital and then cosmetic surgery in his office practice, and he had occasion to be called to deal with an ASA 5E patient from a nursing home with a massive abdominal hernia and gangrenous bowel. And he put the tumescent analgesia in. They gave a little propofol and ketamine judiciously, and the patient not only recovered but was able to be returned to the home. Surprisingly enough, the major anesthesia journals weren't interested in this novel application of tumescent analgesia. So it's tough to present different things to different people. Next slide, please. Okay, laryngospasm associated with ketamine. I did my first 100 cases before I saw this, and I didn't really know what I was dealing with until I put a mask on the patient and tried to ventilate. And so the thing that's different about ketamine as opposed to the other types of laryngospasm is the vocal cords slam completely shut. So there's no crowing noise that says, oh, this is laryngospasm, okay? The only prodrome you're going to get is a cough or a sneeze indicating something's going on in the airway, and the treatment is 1 milligram per pound of lidocaine or 2 milligrams per kilogram IV. And the usual treatment of anterior jaw displacement, positive pressure ventilation doesn't work very well at all. And so I published this finally 6 years ago. On the left-hand side of the 4 pictures in the middle is a BIS monitor showing the EMG trend at the bottom red. This was the first textbook in the field, and I guess it was thought to be such a trivial subject that, of all the hundreds of anesthesia textbooks, nobody had ever written this textbook before. And it's the first textbook to display a BIS brain monitor on the cover, and the first to define sedation levels with reproducible numbers instead of words. Much to my surprise, 2 years after publication, they translated it into Portuguese, and I said, Portuguese? Why Portuguese? It's Barry. That's what they speak in Brazil. And not only that, later I found out that the kind of Portuguese they speak in Brazil is different than the kind of Portuguese they speak in Portugal. What would an anesthesiologist from America know? Okay. And then some years later, they decided to do another translation in Mandarin Chinese. So the information is out there. I'm very excited to have this as, my textbook. And it is on Amazon if you have a burning desire to get it. I think it's also, somebody decided to put it up electronically for free. So there you have it. Next slide, please. So it's not only for cosmetic surgery. In 2004, I was invited to speak at the Brooke Army Hospital in San Antonio, Texas, because they were looking for a more mobile way to provide anesthesia in the forward units. And they were kind enough to write Chapter 7 for my textbook, Propofol Ketamine Beyond Cosmetic Surgery, Implications for Military Medicine and Mass Casualty Anesthesia. For this, I earned a special U.S. Congressional Award as well. Next slide, please. And Phil Larson was my chief at Stanford. This was a memorial they did for him. He was 90 years old in this picture, and he writes as a inscription, "You were a wonderful resident and surpassed that record by creating a new and innovative method of anesthesia that is recognized worldwide as an important advance in anesthesia. You made your Stanford heritage an honor to us, your colleague and friend, Phil Larson." There's nothing like praise from your chief all these years later. It was very, very special to see him and see how well he was doing. You have to remember that the publish or perish world of the academic anesthesia societies produces papers that are 50% never cited. And so to memorialize my contribution, I published this collection of some of my papers and also devoted it to 247 subsequent paper citations and 82 in anesthesia textbooks. Not bad for a guy who's outside of academic anesthesia. Very proud of this. It's on Amazon, and if you email me, I'll email you a copy. It wasn't, again, intended to make money. It was to say, look, this is my claim to fame. This is what I want to be remembered for, and the reason I want to be remembered for is it's just better for patients. It has been a long, strange trip. I'm happy to sit and chat with you for as long time as you have. Hopefully it was a reasonably coherent presentation. I'm ready to take any questions. Thank you very much.
Thank you very much, Barry. It was perfect, clear, nice. So I'm expecting